بسم الله الرحمن الرحيم. برحب بالحضور. عنوان المحاضرة Diabetes in low income countries. Diabetes is a prevalent disease. Diabetes affects approximately 422 million adults worldwide. By 2035, approximately 592 million people worldwide will live with diabetes. Diabetes is a growing problem in low-income and middle-income countries, which already carry about 75% of the global diabetes burden. What about Egypt? A study by Khalil et al. In 2017 in Alexandria, Egypt, 9,657 subjects were included. The prevalence of diabetes was 16.8%. Pre-diabetes, 14.6%. These numbers are substantial. It's a substantial percentage. I think it is higher than worldwide numbers هنقولها بعد شوية. It is an epidemic. Diabetes was most common in people older than 50 years. Pre-diabetes was most common in 30 to 39-year-old men and in women younger than 20. Factors independently associated with pre-diabetes were a history of dyslipidemia, urban residence, and widowhood. أما diabetes it was associated with high waist to hip ratio, family history of diabetes, being divorced, history of dyslipidemia also, peripheral arterial disease or hypertension, low education level, and being out of work. This is in Egypt. Health systems in low and middle income countries like our country, like in Egypt, is typically designed to provide services for maternal and child health and also communicable diseases. This was the case in Egypt till very recently. All the programs, the government programs was directed for maternal and child health and also for treatment and prevention of communicable diseases. By time, the increase in life expectancy will lead to a rapid rise in the burden of other non-communicable diseases, including diabetes, اللي هما diabetes, hypertension, and cardiovascular disease. Economic issues of diabetes is very important because diabetes is a costly disease. All people should receive essential health services without being exposed to financial hardship. In addition to morbidity and mortality, diabetes causes substantial economic burden for individuals, households, and health systems. Health systems in the case that there is an insurance, healthcare insurance systems, but most individuals are not insured. That's why individuals are the ones to carry the burden, the economic burden of diabetes, and secondary to this, the household will suffer. Secondary to the individual being responsible out of his own pocket money or out of his own pocket in order to carry the burden of the economic burden of his disease. The annual cost of diabetes treatment has been estimated to be as high as $825 billion US. This is worldwide cost, the total worldwide cost of diabetes treatment in US dollars. 800 million people spend at least a tenth of their annual household budget on health-related expenses. So it appears that the 800 million people are not health insured and they spend really a lot of money. A tenth of the income is a very big percentage. Out of these, 1 in 8 households is forced to live on $1.9 US or less per day as a result of this. The economic burden of diabetes is due to the very high cost of insulin, particularly for type 1 diabetes, and also type 2 diabetes who are insulin dependent. They also have a very high cost of diabetes treatment. In addition, frequent laboratory tests are also expensive, starting from self-monitoring by the point of care and also laboratory tests done in the lab for control of diabetes, such as hemoglobin A1C, and also complications of diabetes. So complications of diabetes, they carry a lot of tests for their prevention and detection, and also for their treatment. Lack of solid data. To date, analysis on management of diabetes have been limited by scant empirical data on prevalence and utilization of health services. So this is the only source that you can get data for analysis from the small percentage of people who are receiving health services from government institutions. So the data is very lacking. The main reason for that is the absence of universal health insurance coverage that would essentially document all necessary costs and needs. Improved data would be of enormous use to policymakers, clinicians, academics, and civil society worldwide. It is sure that if all the numbers are registered, if there is a universal insurance covering all the population, you can know for sure how much money you need for testing for diabetes, for management of diabetes, for treating diabetes, for managing the complications, and you can provide those needs very easily if you know how much you need. This is a study that was done in 28 low and middle income countries, starting 2008 and ending in 2016. These are the countries that were included in the study. Egypt is not one of them. All low and middle income countries were eligible to be part of this study. Some countries failed to respond, and some countries responded with invalid data. So these were the countries that managed to respond with valid data by the end of the study 2016. In this sample, over 800,000 adults were included in the study. The overall prevalence of diabetes was 8.8%. About half of them, more than half of them, were undiagnosed. This percentage, this prevalence, is lower than our prevalence in Egypt, that was about more than 16% in the study done in Alex. Total unmet needs for diabetes care was defined as the sum of the following. First of all, undetected. Undetected diabetes is a person who was discovered to be diabetic, but he was never tested for diabetes. The healthcare system never asked him to test for diabetes, or he did not reach the institution that is concerned with diabetes testing. So the undetected diabetic person is a person who was never tested for diabetes, and the study found him to be diabetic, him or her. Detected but undiagnosed. This person was tested for diabetes, and the test was positive, but he was not told that he has diabetes. He didn't know that he has diabetes. So when he was included, he or she was included in the study, he was found to be diabetic, and when he was asked, were you tested for diabetes? Yes, I was tested for diabetes. And was it positive? He would say, I don't know. I was not told that it was positive. So this is detected but undiagnosed. Diagnosed but untreated. This person knows that he has diabetes, but he is not receiving any treatment. And lastly, treated but not controlled. He is receiving treatment, but there is the diabetes is not controlled at all. The total sum of all of these malpractice categories was 77%, which is a huge number, of course. This is the same. It will clarify the meaning of the last slide. Those are all the diabetic people included, 100%. This is a percentage, okay. The 63 only of the 100 were tested for diabetes, okay. 44% of the 100 were diagnosed. So the 19%, the remaining 19, the difference between 63 and 44, those 19% were tested for diabetes and were positive for diabetes, but they were not told that they are positive. Okay, and then 38% received treatment, and only 23% were adequately controlled. Performance was better in upper middle income countries. Of course, countries with a higher income were performing better. Overall, only 16 to 25% achieved diabetes control, which is a very, very poor percentage that needs a lot of work to be done. Higher odds of being tested, treated, and achieving control. Who are those having better chances to be tested, treated, and controlled? Increasing age, older person, education, people who are better educated, overweight or obese subjects. It appears that they are more concerned with their health, so they are more frequently being tested for diabetes and treated and controlled. To conclude, there is a large unmet need for diabetes care in these countries that are low income or middle income countries, that reflects the need for a greater investment of health resources to strengthen systems of care for this important prevalent disease. These are my references. Thank you very much.